Dear Chairman and dear colleagues, I'm glad to be part of this elegant meeting again. I'm repeating. I'm supposed to speak about the chemo-associated heart failure. We all know that in the last years, the life expectancy for patients with cancer is steadily improving. But on the other hand, there's a large group at risk of treatment-related complications, and one of which is cardiotoxicity. It has a strong impact on quality of life, patient survival, regardless of the basic problem of the cancer itself. It has a negative impact on the patient's cardiac prognosis, and it causes significant limitation of the therapeutic options, unfortunately. Incidence ranges from 5% to 65% of the treated cases in relation to the total dose of the chemotherapeutic agents administered over the duration of the follow-up also considered. Drugs most frequently associated with the cardiotoxicity are, famous one, anthracyclines, doxorubicin, epirubicin, taxanes, alkylating agents, and trastuzumab specifically. And when we see the cardiotoxicity producing agents as a systemic therapy, I'm here speaking about anthracyclines, alkylating agents, antimicrotubule agents, antimetabolites, monoclonal antibodies, specifically trastuzumab, I'm speaking here again, and hormonal agents. It can be acute or subacute. In this case, you may see alteration of the ventricular repolarization phase, increased duration of the QT, arrhythmias, ischemia, acute heart failure, and most frequently myocarditis and pericarditis-like syndrome. And on the other hand, in the chronic form, it could be early chronic or late chronic. The definition varies and varies. You can see asymptomatic left ventricular dysfunction, systolic and or diastolic dysfunction, or the severe forms of dilated cardiomyopathy and even cardiac death. But recently, Recently, the definition of the chemotherapy-associated heart failure has been revised. You can have a look at this elegant review paper published in the International Journal of Cardiology. They identified at least two subtypes of chemotherapy-associated cardiotoxicity. In the type 1 chemotherapy-associated cardiac dysfunction, it is typically anthracycline-induced chemotherapy cardiotoxicity. It is due to, at least in part, to oxidative stress on cardiac muscle resulting in free radical formation and cell death. It is irreversible, we should keep in mind that, and typically associated with significant ultrastructural changes at biopsy. On the other hand, type 2 form is typically is related with the trastuzumab. Infusion is associated with reversible type of myocardial dysfunction rather than structural damage, and it's highly reversible up to 79% of the cases, and generally is not dose-related, contrary to type 1, which is typically dose-related. And in the pathogenesis, we see peroxidations of the membranes of the influx of calcium, decrease of glutathione peroxidase, mitochondrial dysfunction, which is a typical form, and a depletion of beta stores, and so it leads to oxygen-free radicals in the type 1 form. Anthracyclines, we all know that these are chemotherapy agents commonly used to treat breast cancer and lymphomas, and we all know that they can cause cardiomyopathy now. And the myocyte damage is typically as a result of production of toxic radicals, increase in oxidative stress, lipid peroxidation, vacuolation, and myocyte replacement by fibrous tissue. It is induced and it is related to cumulative dose of the agent that is used, and it occurs about 11% of cancer patients after a cumulative dose of less than 400 milligrams per square meter of body surface area, and the incidence can increase up to 100% if the patient is exposed to 800 milligrams of anthracycline per square meter of body surface area. There are other risk factors also on top of cumulative dose, such as age, other cardiotoxic chemotherapy agents, radiation, and also history of cardiovascular disease. Chemo-induced cardiomyopathy produces typical symptoms that we see in the clinical practice, typical palpitations, shortness of breath, chest pain, fatigue, but they may, on the other hand, result in acute cardiovascular complications in short-term with arrhythmic potentials. In the chronic cardiotoxicity, we see typical clinical heart failure, and there may be also linked with being acute and chronic cardiotoxicity of these agents. That is the reason ACC and AHA identifies this group, treatment with cardiotoxic drugs, previous exposure to cardiotoxic drugs, as to be included in the stage A patients. They are considered as the high-risk patients. To me, actually, they should be considered as very high-risk patients, and they have to be screened for the presence of cardiotoxicity. How should we do this screening? We should identify the patients at high risk for developing cardiotoxicity. We should diagnose and treat the left ventricular dysfunction to prevent progression to clinically overt heart failure. What about risk factors? We know that total dose for the doxorubicin case, whether it is pediatric or geriatric, it is also important because in the geriatric case, we have history of CVD, so the patient has a tendency for the cardiovascular disease. Prior cardiotoxic treatments is a very, very essential component of the screening for the cardiotoxicity. Presence of genetic cardiovascular risk. Some patients may have a tendency to develop heart failure, and if these patients are exposed to cardiotoxic agents, they develop more frequently heart failure, body mass index, and the females are more prone to. How should I early identify? It is called early identification, but I personally do not agree. But if you see a decrease in the ejection fraction of 10%, more than 10%, or if the ejection fraction goes below 50%, we should supposed to discontinue the treatment of these chemotherapeutic agents. Before beginning the therapy, a value of less than 50% is a criterion for exclusion from the treatment. And during therapy, the cardiac functionality must be monitored every 9 to 12 weeks in these patients. But we all know that changes in the ejection fraction and the timing of the detection with several screening strategies during and after cancer treatment varies. Ejection fraction is a very crude sign of decreased myocardial function, is a very late sequela of the cardiotoxicity. So we need something earlier to identify, to understand, so that we can prevent actually really the occurrence of overt clinical heart failure. That is the reason new echo technologies are very frequently being utilized as the quantitative evaluation of the global, regional, radial, longitudinal, systolic and diastolic myocardial function, just to help us to identify as early as possible the occurrence of the myocardial toxicity. But what about biomarkers? Should we rely on more biomarkers than the echocardiography? From my point of view, I think yes. I'm going to show you a very, very recent paper published in JACC very recently. And in this study, the authors measured multiple biomarkers, including BNPs, troponins, and the myeloperoxidase. And they just regularly visit the patients, regularly see the patients along with the biomarkers and the echocardiography study, and identify that whether, and particularly I just draw your attention to the case that these patients are breast cancer patients treated with the doxorubicin and the trastuzumab, the most frequently cited two agents in this category. And the authors found that each increase in the standard deviation of troponin, something like a change of 100 milligrams per liter, there was nearly a 40% increased risk of subsequent cardiotoxicity, and this was valid for the myeloperoxidase case. I know that myeloperoxidase is not part of our routine practice, but troponin is kind of our routine practice, so I strongly recommend everybody, if your patient is on chemotherapeutic agents, they should regularly be screened for the troponin elevation, because troponin elevation means something is going wrong. And what about the prevention or treatment, let's say? It's not kind of prevention, but it's kind of a treatment as well. But if we use carvedilol in patients who are undergoing adriamycin therapy, adriamycin-based chemotherapy, you can actually prevent, you can actually be protective against the cardiotoxicity of these agents. There are publications in the literature. What about ACE inhibition? ACE inhibition also appears to be quite important for the prevention of cardiotoxicity, in prevention of development of heart failure and arrhythmias requiring treatment in these patients. On the other hand, dexrazoxane, it's difficult to pronounce actually, it's kind of an iron chelator and has been shown to prevent or reduce the severity of heart damage typically related with the anthracyclines caused by doxorubicin. And it's thought to protect the heart muscle just by blocking the formation of oxygen-free radicals, which is typical, the main pathway of anthracycline-induced cardiotoxicity. And this is, I know it's very little, it's difficult to follow. I'm sorry for just the bad quality of the picture, but it's a very recent systematic review and meta-analysis published very recently in the European Journal of Cancer in 2013. And the authors shown that not only statins, but also ACE inhibitors, beta blockers, and also the agent that I said, dexrazoxane, it's difficult to pronounce, iron chelator, are beneficial, not only prevention, but also treatment of chemotherapy-induced cardiotoxicity. So we have chance now to prevent further deterioration, to prevent the occurrence of cardiotoxicity, and also treat the chemotherapy-induced cardiotoxicity of these patients. Thank you for your attention.